Good afternoon, my lady. Lord Bethel, I hope you'll indulge me just to continue using the documents to give an overview chronology around the scaling up of the national testing programme, please. Please could we display 566069? That's 566069, please. Thank you. Now, Lord Bethel, the date's not on the front of this, but the information we have is this is now the 22nd of March of 2020. And we can see this was the briefing put together for the Prime Minister. And if we move through, I'm not intending to dwell on the pages, but we really see the evolution as we move through the pages of the ambition, but also the practical things that were happening to get the laboratory test centres and distribution centres set up.
This is how not to do a test lab, by the way.
Okay. But we also see as well there's plainly been forecasting, modelling and projections as to the scale up. Thank you.
I mean, it's just an incredibly thoughtful and data-driven amount of work. I hope this sort of presentation, I hope, gives you an idea of what was involved.
Thank you. We could keep going just so, and I mean, no disrespect to the project, Lord Bethel, with not going through the detail of it, but it gives an idea as to the evolution of, perhaps if what we look at page 21, we keep going, I think what you've described as the battle plan. And I don't know whether this is in the context of what you've said already about scramble and the culture of scrambling. But can we then move to another document? Because we've then got what we've analysed in detail, and I promise I'm not going to take you through the 168 plan of Deloitte, other than to identify it. Please. Sorry, I'm going to need my glasses for this one. I do apologise. INQ 581552. Now, can I ask... Sorry. So it's the 168 plan of Deloitte 581552. I hope that it's not a 6. It might be 561552. I do apologise. Deloitte did recommend we use the hard copy. Sorry. Thank you for your patience, Lord Bethel. Now, Lord Bethel, this draft has got the June date on it, but with the evidence of Mr. Cook for Deloitte, we had an earlier iteration of the 25th of March, which follows on from the PM's briefing. This is how it develops a little bit more by the June. But did you see and have access to the Deloitte 168 plan to understand how they were bringing together the strands and the flow, as we can see on this, of Kingfisher, Roche, NHS and digital platforms to bring the project to fruition?
Yes, well, I was very involved in, at this stage, all steps of it. Many of them were based on the 6th floor below my office, and I had daily engagement with the team on their progress.
Thank you. And I think, in fact, you tell us in your witness statement, was it from the 19th of March there was a Deloitte team located in Victoria?
Yes, there was, downstairs, absolutely.
Thank you. Now, pausing where we are in the chronology, I have a number of questions to contextualise the scale-up of the industry. And so can I ask, from your perspective, Lord Bethel, was there sufficient consideration given to working with universities as laboratories?
Yes. I mean, I think we've been through this quite a lot. A huge amount of effort went into not just universities, but hospital pathology labs, animal pathology labs, all manner of private, public, and university testing laboratories in order to create, out of the battalion of small ships, some kind of network that could somehow utilise this expertise, infrastructure and passion, because they were very enthusiastic. And I was lobbied on an hourly basis by just about everyone who had a PCR machine about how they could play an important role. And I personally spent a huge amount of effort to try to figure out a way of creating an Uber for diagnostics. And that vision, I thought, was a very powerful one. Matthew Gould wrote a very thoughtful note on how we could apply modern insight from Silicon Valley on how to somehow harness this collective effort. It was a total disaster. It just didn't work. They were regularly late, they regularly lost tests. the turnaround times weren't quick enough, the data got in a mess, it was very, very expensive. And I would have loved for that effort to have worked. But the thought that it in any way could play a significant role is not just a distraction. It is, as I said in my opening remarks, promulgating this status quo mentality that we don't need to change anything in the way that this country does health, that backing acute care in the NHS and research in life sciences is enough. And we need to focus on this thought that public health diagnostics is a different beast, and we need to think about how we provide a platform for scaled up industrial throughput if we're going to be ready for the next pandemic.
Well, Bethel, you're obviously very thoughtful about this. I don't think you were on the last couple of times you've helped me. I have to craft recommendations. You're a politician.
Yeah.
And you know that there's a temptation for governments of whatever political hue to focus on the immediate problems, not necessarily spend as much on the long term. Is there a way you can think of where I could craft a recommendation, accepting the points you make about the underinvestment in public health and not prioritising it, where you could craft a recommendation that might be attractive to government?
Yes.
Because it wouldn't be just an insurance policy, it could be something that could be cost effective now.
Yes, I understand your priority and strongly support it. And I will try to give you what you've asked for in a second. But if I may just sort of make my intervention to you, my biggest fear about where this module is going is that you are looking for a sort of list of micro recommendations of around the sort of 10 million to 50 million ticket. And it would be great if that was the answer, but genuinely I don't think it is. I think that there are two things that you need to lean into. One is the fact that we have utterly defunded public health. UXA was meant to be a kick-ass, cross-departmental organisation of the kind like the National Security Council, run by really senior, well-paid people with good scientific budgets and a reach into local government. And that hasn't worked out at all. It is a microscopic version of what it should be. And that is an indication of a broad defunding of public health across the board. And we see that in NHS screening, NHS vaccinations, health checks. In other words, we have abandoned the idea of prevention, and the disciplines around prevention are what you need to create the foundation for the pandemic response. So there is a direct link between defunding prevention-style public health and not being ready for the next pandemic. And secondly, it would be very important to have the underlying health of our nation improved. Because if there is one thing that caused a pile-up at ICU units, is that we have 42% of the country are overweight. And it was those people who were hit hardest by the virus. So if we want to be ready for the next pandemic, I know that this is a long way from the kind of bite-sized recommendation that you're asking me for, but really you should look at what is the state of the underlying health of our nation, and that needs to be put on. We need to find political space for our leaders to be able to prioritise that. Now, to try to be helpful...
No, I'm not interested in just a bite size. Yeah. I mean, obviously, if I can get it implemented, I'd be happy to think of any size recommendation.
Listen, maybe it's not for me to say what this inquiry to do, but I honestly think that you should have a module on the underlying health of Britain, and you should have a module on 21st century public health. And I'd be very happy to design those two modules for you, and I'm brimming with ideas for how they might play out.
I've got to stick to my terms of reference, Lord Bethel, I'm afraid.
Yeah.
So I can't do that. But so basically, your argument would be that investment in public health would be cost effective because it would be cost effective for now.
Yes.
And would then be cost effective for the pandemic.
Yes.
And what it that way.
That's right. And what I'm saying is not some kind of wonkish, weird suggestion. It is how mainstream health systems in the Western world are going about their business. And Britain is unusual for turning its back on what I'm calling a modern 21st century health system, with the foundational pillars of on-the-ground local health, and you had a very helpful discussion about local directors of public health. It's an embarrassment. It is awful how little resources they have available. Day-to-day prevention, testing, screening, vaccination, public health, data that flows both from in and out of the NHS and into local authorities, a workforce that is trained, available, and can then be redeployed in a pandemic, and lastly, a private industry that has, in other words, a prevent tech industry, for which we don't really have one in this country, which is very, very unusual. We have a wonderful pharmaceutical industry, we have biotech, we don't have prevent tech. So those are the 5 pillars that I would recommend.
Thank you very much.
Lord Bethell, just on the chronology, we know that the UK government moved from the contain to the delay phase on the 12th of March and what that meant for testing. But can I ask, in terms of the small boats that were offering assistance, in particular the Crick Institute, I'm going to also ask you to deal with the dealings you had with Sir Paul Nurse, because certainly Mr Hancock has suggested you'd had some relevant contact.
Yes, I spoke to him the whole time.
Well, we'll come on to that in a moment. But can I ask, first of all, in terms of whilst the Lighthouse laboratories were being set up, had the United Kingdom government utilised the offers from laboratories, research institutes and universities, could that have essentially impacted on the decision to move from contain to delay? So there was another option to consider?
No, we used every single scrap of capacity we had. I spent hours every day on the phone to just about anyone who had anything like a testing kit available. I spent a lot of time talking to the animal veterinary industry, the racehorse industry in Newmarket, a very wonderful team at Cambridge University, who, sponsored by AstraZeneca, did stand up a laboratory. My goodness, we looked at every single laboratory. We also looked at every single test. We looked at breath tests, cough tests, poo tests, water tests, pee tests, sweat tests. We had a whole partnership scheme run by the very able Lord O'Shaughnessy, looking at every single test and every single laboratory in the country. We bust a gut to try to make the system that you're describing work, and it didn't. It failed completely, because you cannot go to somewhere like the Crick. And I don't know if you've been to the Crick, but it's an absolutely stunning building, and it's won design awards, and it has one feature to it which is incredibly exciting in order to encourage creativity. It has no walls. No walls, a building without walls, really exciting. This is not a place that you want to base a laboratory for a highly contagious disease. I mean, this doesn't make sense. I went to the Cambridge University laboratory. I nearly ran out in anxiety. There were piles of tests in the corner. You had to climb over things in order to get to one place to another. Compare that to the Rosalind Franklin, which is in a massive white box just off a motorway, where the tests arrive at 6, 7 in the evening, are automatically unzipped. Unzipping a test is a very dangerous thing to be doing. You don't have to have teams of students doing it. You have robots unpicking them. They then get put into a massive conveyor belt, which is about 100 yards long. It's banging them out on strips, no trays, strips, and doing 30,000 on one machine in an hour. This is a million miles from Paul Nurse and all the others, but that's what you need.
And I don't mean to interrupt you, Lord Bethell. Well, we have here from Professor McNally, who set up with part of the Milton Keynes laboratory, so we understand something as to the process, and equally I think there's quite a lot of videos on YouTube if anyone wants to look at it in action. But then because Mr Hancock giving evidence referenced discussions you were having with Sir Paul Nurse, do you want to just give some context to anything you want to tell us that's relevant to this discussion around scaling up by reference to the conversations you were having with Sir Paul Nurse?
Sure. Paul is a complete hero. I think I've said in the last module that I had a sense of where is everyone, why is there no one to help? Paul was there. He went above and beyond to try and stand up a testing facility when the country needed it, and deserves our praise and thanks. But Paul was writing to everyone. He was writing to the CMO's office about his scientific insight, and he wasn't getting the reply he needed. If you're writing with scientific insight, you need to write to the scientists, to the chief scientific advisor or to the CMO. And if you're not getting a reply, you need to ring them up. phoning ministers because the CMO hasn't returned is a misreading of how government works. And if you've got ideas about the NHS and nosocomial infection, you need to write to the head of the NHS, because the way that our NHS works is that ministers do not tell the head of the NHS how to run the NHS. I had a lot of sympathy for what he was saying. On asymptomatic infection and nosocomial infection, I thought he was absolutely right. We had a large number of conversations about it, and I was just looking at my phone just now. There are dozens and dozens of text messages and missed calls between us. He went on the Today programme after one of our calls to complain about the lack of action on nosocomial infection, and he referred to me as a blancmange, which was something that didn't do much to improve our relationship, but we stayed in touch. And I'm baffled by the way in which he's described that people didn't get back to him.
Thank you. Can we then go back to complete for my assistance, please, the chronology, again, that gives a perspective about what you were doing in March through to April, please. INQ 119438, please. That's INQ 119438. Now, again, I don't want to dwell long on this because we've heard from Professor Malloy about his leaning in, as you call it. This is the 26th of March. A co-signed letter from you and Mr Hancock thanking Sir John Bell for the very generous offer of voluntary support during this time of national emergency. We've already identified both by the slides of the PM briefing the role that Sir John Bell had as part of the team that were stepping up the testing. But if we move over the page, please, we can see that this was really a thanks as him being one of the many individuals that form part of this testing scientific advisory panel that was working until the handover to the test and trace in the May and then ultimately to UXA. But again, is this an example of the selflessness of a number of professionals to assist with the national effort?
It was, but the purpose of this letter was much more important than that. It was to give a licence to trade to a team of people who are going to validate tests, because there was a gap left by BHE for who was actually going to say which tests worked and which didn't. And this became incredibly important once we realised that quite a lot of the tests that were being sold to us didn't actually work. And this team did very valuable work at calling out the tests that were not scientifically proven and led, therefore, to tests that could be proven, and as a result, we bought 3.5 billion of them.
Thank you. And can we please then display INQ 497424, please, which is the terms of reference for the testing task force. That's INQ 497424, please. Thank you. And it's the next page, really, where we have an ability to identify in a quick way those that were part of the task force. We can see the various names there that comprised the team. Thank you. We could scroll up. Thank you. So we've heard from Professor Malloy. Thank you. And can I ask you then, when we look at this testing task force, we don't see anyone from Deloitte as part of the task force.
No.
Is there any reason why they weren't part of the task force?
Yes, they were a delivery partner. The instructions to Deloitte would have been given to them by officials. And I should just clarify, in terms of my personal meetings, my meetings would largely be with officials who would then pass policy on to Deloitte. Periodically, in order to overcome operational problems, I met with Deloitte officials, but that wouldn't be the typical run of things.
And I think you tell us in the witness statement, essentially, after those initial contacts with Deloitte, that you were no part of the setting up of the contract.
No.
Thank you.
No way.
Now, again, just on the timeline, if we could display, please, INQ 106325. Thank you. This is now the 4th of April. We know this is when the Lighthouse laboratories were starting to come online, the scaling up of the testing programme. And please, if we can move through this document. Thank you. And if we can move through till we get to the pillars, we've already, which is on page 8, please. Thank you. And over the page again to the Public Health England partnerships at that time. So I think this is showing I think the PHE-Roche partnership, so this is just a time just before the 4 lighthouse laboratories came online. But if we go over the page, please, we can see that the Pillar 2 testing for which the lighthouse laboratories were to assist is in the latter part of this document. And then if we go over the page, please, we then see the plan for Pillar 3, and over the page again, Pillar 4, surveillance testing, and then finally the Pillar 5 and the plan for spearheading a diagnostics national effort. Lord Bethel, I know that was the plan in April of 2020, but the evolution of the pillars, I think, differed really over the course of the period. Is there anything you want to say about the evolution of the pillars?
Well, they did evolve a little bit, but not really. I mean, it remained pretty much the structure of things. I'd say that the Pillar 5 only really kicked in after a few months when we started to try to build a local industry, and that was a struggle and has faded away. Pillar 4 was slow to start but delivered amazing surveillance data, and I would say in that Britain was ahead of anywhere else in the world. Pillar 3 fell away except for trying to understand the science of the virus became very important. But it was Pillar 2 that delivered the mass throughput testing. Pillar 1, NHS testing, their NHS colleagues did struggle with capacity all the time. And one of the, and this is an area that many people, including Paul Nurse, emphasised, is asymptomatic testing in hospitals remains something that was a real challenge in the UK and could be an area for your recommendations.
Thank you. And do you want to expand upon that with
yes,
line of recommendation?
I mean, if you have 1.5 million people going to hospitals and care settings where there are a lot of sick people, there is therefore a lot of virus in the air. And as a result, we had up to 12% of our own workforce ill. By the way, in a really bad pandemic, you can have half or more. So it's very, very important. I don't think we ever figured out a formula for protecting people from the virus and testing them on a sufficient scale, and also having the workforce consequentials of replacing people who had then been isolated. And NHS colleagues were understandably but frustratingly concerned about testing because they thought it might lead to 10, 20, 30% of the workforce literally being sent home, which was something that they couldn't sustain if they wanted to keep the NHS going.
Thank you. Can we next move then on the chronology? And I appreciate we're looking just at snapshots. I know that there's huge industry over the timeline, but I'm trying to use documents that I hope tell the narrative in an efficient way, but this is no way meant to reflect all of the chronology. But please, can we go to INQ 88699, please, which are the COVID Strategy Ministerial Group from the 14th of April. That's INQ 88699. Thank you. And we can see that you and Mr. Hancock were present at that meeting. If we go over the page again, we can see other members of the testing. So we've got an official who was the Director for Testing. In fact, she's named Cathy Hall, Director for Testing. Thank you. But I've gone to this one because you've offered a view on international comparators, and I think this is quite a helpful document to use. Can we move forward, please? 4 pages. I'm sorry, the numbering's cut off my copy. So it should be the page that starts with "told that" at the top. There we go. Can I ask you then, because we can see that there's a discussion about Taiwan here, and I think again in your statement you make a recommendation around, or a reflection that there was perhaps not sufficient consideration of the Taiwan. And so I don't know whether you're using this, you want to provide your views linked to the international models that you were considered.
Thank you. My wife is originally Taiwanese, therefore I was speaking to my family in Taiwan all the time, and it was personally very striking to me that they were very well informed by SARS. It had been a really bruising experience for the country, and they had completely changed their protocols. And it was a shame that we hadn't changed ours, and I think that's been quite widely discussed. I remember, as a brief anecdote, phoning up my in-laws, and when my father-in-law was sent to the shops very early on, when he came back, he had to take all his clothes off, put them in a black plastic bag, and then my mother-in-law would squirt him with Dettol, and then he was allowed to come in order to have a shower. And when they said that to me, I literally laughed out loud. I thought, how ridiculous. Boy, they had a point. I mean, in other words, other countries were on it straight away. And when I brought this up amongst colleagues at the HSC, they likewise had a good laugh and said, well, you know, Asian culture is very different. That kind of attitude, I think, was a mistake. There's lots you could say about that attitude, but epidemiologically, at least, it was a mistake.
Thank you. And if we move over the page, 2 pages, please. Again, thank you. Next page, please. And if we could scroll up, please. Essentially, it references at this stage now we've got 3 of the super labs running and that they'll be ramping up production well. And can I then please display the Lighthouse lab map just to again look at this on the chronology. 587456, please. 587456. Thank you. And so there's reference to 3, but we know in April of 2020, 4 then Lighthouse laboratories were available in Milton Keynes, Cambridge, Glasgow, and Alderley Park.
Yeah.
Thank you. And then can I ask from your perspective, because obviously great deal of effort to get the 4 Lighthouse labs up and running, but then there seems to be quite a delay between the next set of Lighthouse laboratories coming online. And can you offer any perspective or commentary about what seems to be a really great start, but then a slight longer delay with the rest of the Lighthouse labs coming on?
Well, I think that Cambridge actually was stood down. That wasn't really a mass throughput lab, although I think scale counted for a huge amount. We didn't necessarily need a lot of labs. We just needed really big ones, because the insight we learned was moving the samples around could be done quite quickly. It was more important that they were accurate and quick. The Leamington Spa lab that came in June was really the big mothership, and that one for me was a model of the kind that we should be having in the future. The idea that there was going to be a second wave was something that a lot of people really struggled with. It was something that Chris Whitty said to us in January. When he first said it to me, I couldn't get my head around it. But instinctively, emotionally, culturally, I think that a lot of people in senior leadership positions resisted the idea, and that did create a bit of a stall in progress.
And can I then obviously reference the mothership, the Rosalind Franklin? Obviously, there's been quite a lot written about that in terms of the cost and expense. And then obviously, again, all of this gone. Can I ask for any views you have? We heard yesterday from Vaughan Gething that essentially they were part of the investment in this structure,
yes,
and no one consulted them before they were all mothballed. And I think that felt like if they've contributed financially as a nation, a government, that someone should have at least done them the courtesy of speaking to them about the plan before they were decommissioned. Can I have your perspective on that, please, Lord Bethell?
Well, he's got a point on courtesy, but that's not really the serious point. There was no consultation with the future pandemic thinking strategy team about how we should mothball this. I remember I obviously got sacked in September. One of my last meetings was when DHSC colleagues had tabled an idea for how we should have a phased retreat and how we should try to preserve some of the infrastructure from test and trace in order to create the kind of capability that we're talking about. And when we met with NHS colleagues, they had a completely different plan that I was shocked and surprised to see, but I now understand prevailed, which was to essentially dismember the entire outfit, to ransack it for stuff that the NHS need, and to sell the rest on eBay. How that decision was arrived at, I think, was disappointing and definitely did not include the kind of strategic thinking that should have happened and that this inquiry should be calling for.
Thank you. Thank you. Can they just a few more documents now, please, Lord Bethell, that I hope give some insight. Can we move them, please, to 592613? That's 592613, please. Just going back to the pillars, this is a document you authored to give an update on Pillar 4 from the 15th of April. And again, if we move into the document, I think you've described others as thoughtful. If we move through again, we can see the update and progress that was being collated to speak to each of the pillars. And I think this is just one example, but is it right that these were being prepared throughout the period of the time?
I can't speak more. All of the time there was very thoughtful, data-driven analysis, very tricky questions about what kind of post to use, what kind of swab to use, what kind of tube to use, which machines, where we're going to get our biomedical workforce from. Hundreds of knotty little problems, really analysed very carefully. So there was a massive investment that went into the creation of this system, and I hope very much indeed it has been preserved, and would be disappointed if it wasn't.
Thank you. Can we next then please move to INQ 592636, please? (592.636), and again on the timeline, although there's not an immediately apparent date, this document is dated the 21st of April 2020. We can see contact tracing and testing. We've already heard quite a lot of evidence about the apps and the development of the apps. I don't want to use the precious time we've got to deal with that, but can we go over the page, please, and really seek your input with what we see here in the pyramid and the criticism that's been levelled by a number, including Lord Agnew in Module 5, as to how it was 15,000 call handlers were in a test centre that were never really fully utilised, and the cost and expense that caused. And can I, whilst dealing with this topic, you describe essentially creating contact tracing from scratch.
Yeah.
You've obviously already made comments about directors of public health. We've statements from the Local Government Association and the Associate Directors of Public Health, and I think they feel that they were really underutilised. And we know that they came on later, but can you offer your opinion now on this whole issue of contact tracers in a central call centre, remote from their local communities, not knowing their local communities, and then the move to include the Directors of Public Health, please?
Absolutely. Do you mind if I'm going to do it in the other order, if you don't mind?
I appreciate I've rolled up a lot of questions there.
Sure.
But
so essentially on the central and local point, Matt Hancock kind of dealt with this, and I would just build on what he said. Without doubt, having local contact tracing is basically better than national. It is what they have in places like Korea. We have in the UK neighbourhood policing. In my ward, we have a sergeant, a constable, and a special. They know my ward, and they deal with crime extremely well. We do not have the equivalent in public health. They do in some other countries, and in those countries, a local public health official understands that community and has the kit in order to deal with things like a pandemic. That is definitely a better way of doing things, but we don't have it. I would strongly support the inquiry looking at whether that is something that Britain should be looking at more closely.
thank you.
Secondly, in terms of the standing up, and therefore, just as a final point, we kind of got there towards the end, and we had a mixture of the national programme and hopefully worked with local directors of public health and others in order to do the local implementation. But I agree that it was a shame it took us a long time to get there, but under the circumstances, I think we did very well.
And Lord Bethell, can I then be absolutely clear? I asked the question of Mr. Hancock, because on one view, when you look at it, it almost looked like, did actually the decision makers at this time appreciate that there was this resource of local authority, directors of public health contact tracing? It seems from what you've said so far you knew about it.
Yes.
But can I just be clear that you appreciated when you talked about essentially doing contact tracing from scratch, that you completely appreciated the role of the directors of public health?
Absolutely. And although I'd been new in post, I'd been given a very clear briefing about their importance. There is some variety in the quality, but some of them are absolutely stunning figures. And someone like Kevin Fenton here in London, we worked extremely closely with, and there were about a dozen of them who I spoke to on the phone all the time. But if I may just give you an example of how minimal the resources are on a local basis. I remember doing a roundtable with Zoom call with leaders of local authorities about standing up tracing in their areas. And I said, what we're going to do is we're going to have a car park, and we're going to have a table with a gazebo on it. We're going to send you some squaddies. They're going to do the swabbing. Could you please sort things out? And the question was, where do we get the gazebo from? In other words, resources are so thin on the ground, they needed 500 quid to buy a few gazebos because they didn't have the spare cash to do that. So the idea that we could have somehow handed responsibility for tracing and testing to people in those situations is just not realistic.
Thank you. And I think you've already identified, you think you got it right in the latter period where the local resource was then brought in?
Yes. I mean, we recognised from the beginning that local is best, but we needed to stand something up quickly.
We've heard one example, what was done in Leicester and Sandwell, about, I think, where essentially they took a grip and started doing local contact tracing. Did those sorts of actions in certain local authorities highlight the need that something was missing?
Yeah, but I remember Leicester. You remember what happened in Leicester and the mayor and everything? That happened partly because we sent them a ton of money and people and officials and contracts. I remember sending them telephone numbers of people that they could call. There was a lot of support from the centre of some of these local initiatives, and that wouldn't have happened if we hadn't have got behind the idea of local tracing.
Thank you. And then finally, for the chronology...
Do you want me just to quickly say about the Lord Agnew point?
Yeah, oh, sorry, yes, please do. And then there's another Lord Agnew point I'll go to.
Oh, good. Listen, they weren't in call centres. They were working from home. So work from home, just a few things to remember. Work from home then was new. No one had really done it before. And we were recruiting a new force. Also, don't underestimate how spiky use of something like this is. It would go to nothing and then go up very quickly. So as we were entering the second, well, not even, we could see the second wave coming. So we needed to train and also make capable 20,000 people or so. We had to send quite a lot of them laptops. Initially, there was great cybersecurity issues. So some of them were doing strange things with their laptops. Those all had to be locked down. They had to be given some hours of training. There was a waterfall of training that had to be gone through. Some of them were not capable, so they had to be taken off. In other words, standing up something like that is a non-trivial exercise, and you can't predict exactly when the spike is going to be. So we did amazingly to get 20,000 people working from home up to speed on how to do tracing, and then also to insert the extra level of expertise needed for complex cases. That happened very, very quickly. Theo is right that at times usage was very low, but that is just a fact of life if you're dealing with a highly spiky virus.
Thank you. And then just to identify another issue that Lord Agnew has raised, can we go please to INQ 471020? INQ 00471020, please. Thank you. And can we move forward to page 3? Now, I'm not suggesting you're copied into these, and you may have had nothing to do with the financials and this scenario, but again, with dealing with issues that Lord Agnew has identified, we can see this is in July of 2020, where he was being asked to approve, by reference to test, trace and isolate, £1.25 billion programme in one day, which plainly he's identified as being ridiculous, and asking the question, what interaction has there been since the meeting on the 27th of May? And over the page, again, we see him querying aspects of the pricing and the costings. Can I ask you then, is any aspect of this something that you had input on? Or,
yeah, sure, of course.
Or can we have your perspective on this sort of very short window to approve eye-watering amounts from Lord Agnew, which plainly he was concerned about?
Yes. So you have put up already a huge amount of very clear data-driven analysis from the test and trace team. That was all available to Cabinet Office colleagues on request whenever they liked. There was absolutely no shroud of secrecy at all. In fact, we were very evangelical about the work we were doing. I was happy to talk to anyone about it that they liked. There is quite well-documented correspondence between the test and trace team and Cabinet Office about the one-day sign-off incident. I don't recognise Theo's description of it being a half-day opportunity to sign something off. I think that that's a question that should be put to his Cabinet Office colleagues on why that sub was only put on his table at the last minute. We were desperate to get large parts of government involved creatively and practically in the funding, finance and implementation of this, it was quite hard to get their attention. I think a lot of them rather hoped that there wouldn't be future spikes. There was this cognitive challenge of trying to get people to believe that this was a 3-year challenge, not a Easter challenge. And I think it would have been better if the whole of government had had a slightly more realistic attitude to the length of which, the long period in which COVID was going to be hitting us.
Thank you. And then finally, please, for the chronology, can we move to 497170, please? 497170. Thank you. We're now at the 28th of May 2020, and we can see that the decision was made to pause the task force. It's said here for the next few weeks. But is it right? This was essentially the end of the task force at the time.
The task force was a sort of band of brothers, I think unfortunate phrase, but it was meant to be a scratch team of people from a lot of different backgrounds, including the private sector, who were going to throw themselves into hacking, jump-starting this project. So it quite reasonably got retired the moment we had proper structures in place.
Thank you. And we can see it was stood down because Baroness Dido Harding was taking up the reins.
Absolutely.
And we're going to be hearing from her next week about what she did. But I think until you left your post, in reality, you were still over all of these issues linked to test, trace and isolate. Is that correct?
Yes, although it became like a functioning, proper agency of government and needed much less of my involvement in later on.
Thank you. Lord Bethell, that was my intention as to the chronology. Is there any aspect that you think is important of the chronology that we've not dealt with that essentially helps tell the story of the scaling up of testing in the Lighthouse laboratories?
Well, the only thing I'd say is that's right. You've asked questions about the scaling up period. I would just emphasise that, for instance, on genomic analysis of the virus, there was a huge amount of expertise and important science that went into other aspects of this that shouldn't be overlooked. And there were parts of the surveillance and research components, and also the implementation of the community-led testing that really only matured later on. And so you're putting a spotlight on almost the most difficult period, and maybe not at what the situation was when it was at a sort of running speed. And I think I would hope very much indeed you could look at that and see what the benefits were of getting the system up and running.
Thank you. Can I then, for the final part of my time with you, just deal with some discrete topics, and then we'll finally deal with anything else you want to say about lessons learning. Can I ask you about symptomology and the inquiries heard evidence from Professor Spector around the different symptoms and when they had identified loss of taste and smell as a symptom and indicator, and certainly by the 1st of April it was on their website. Were the Test and Trace Task Force aware of those additional symptoms before they were formally recognised on the 18th of May 2020?
Yes, absolutely we were. Thank you for raising this. I can't emphasise enough how complicated the symptomology of this virus was. Lots of people had lots of different symptoms. Some lost taste, some didn't. Some coughed, some didn't. Some had headaches, some didn't. There was no categoric symptom for COVID. Now, if you have measles and you put a glass and there's a little round, that's a symptom. You know if you've got measles. It is just not true with COVID. Early on, most of the people who thought they had a cold probably had COVID. Later on, most of the people who thought they had COVID probably had a cold. Professor Spector is a serious scientist who I respect a lot, but he should know that you cannot test for COVID on symptoms, and that his app, although a fascinating and interesting use of patient data, a principle that I happen to support, simply isn't an accurate definition or surveillance tool for COVID.
Thank you. Can I then please ask you about some questions around asymptomatic exposure, please? And can we please display INQ 279754, please? That's 279754. And there's a number of questions I just want to ask around asymptomatic. So this is Catherine Halsbury from the Department of Health and Social Care. querying whether there had been asymptomatic exposure in Birmingham and London in an email exchange with you on the 31st of March 2020, which was to be included in your readout. Given that the query raised, why wasn't asymptomatic transmission included in test and trace policy at this stage?
I'm so sorry, but I don't understand the question. Do you mind putting that to me again?
So, I mean, if I do it under a more general issue,
Yeah.
certainly the knowledge and evolution of asymptomatic transmission, and I think we've heard a lot of that from from Mr. Hancock, but did there come a time before, when we've heard that it was formally accepted by Mr. Hancock and policy changed at the end of April, did you appreciate that actually you should have been doing something to accommodate asymptomatic transmission within the policy and decision-making around the test and trace strategies?
Yes. Well, thank you for asking me. Well, not with the risk of re-prosecuting the conversation from earlier today or triggering in myself any anxieties. I've got to be honest with you that the discussion around asymptomatic transmission was absolutely at the heart of everything we did from the very beginning. For me personally, I noted that in the chalet of super spreaders, which you may remember began the COVID experience for Britain, when I think it was about 10 doctors who had been on a skiing trip, brought COVID and then spread it all around the country. A very notable feature of that story struck me, which was that in their chalet, none of them had symptoms. So that's the question. How did these 10 people all catch COVID off each other and none of them had a symptom? So that question of asymptomatic transmission was crystal clear to everyone, but it took until April the 14th to get the clinical advice that we could put asymptomatic infection into our policy making. So to answer your question directly, no, we were led by the science, and it was very much how we rolled, and we were respectful of the experts. But until the April the 14th advice came through, no, asymptomatic infection wasn't in our official policies. I must admit that I, like many other people, assumed that this day was going to come, and therefore we did build it into our thinking.
Thank you. Can that be taken from the screen? Can I ask you, we've heard some evidence about Operation Moonshot and how that then became part of the community testing programme. Did you have any concerns when the Prime Minister announced his big Operation Moonshot as a policy or a proposition before it then essentially used the tests that had been developed to move into the universal testing offer?
Yes. Well, yes and no. On the one hand, I was thrilled that mass community testing had such strong sponsorship from the Prime Minister, and that he had become super engaged in the opportunity there. So I was absolutely delighted to ride the tide of his enthusiasm on this. There was a piece of Moonshot, which was the idea in Slovakia that you could somehow eradicate the virus altogether from the community and have it open. Actually, I don't think that was realistic. You can use test and trace to keep levels down, but if you're running red hot, if you've got a prevalence of 1%, 2%, 3%, as I said earlier, testing can't really fight against that kind of tidal wave. So I did have hesitations about the idea of a total zero COVID strategy, in as much as that was part of Moonshot thinking at some parts.
Thank you. And can I ask then, in terms of you referencing Slovakia, I think that's very different in any event because they have a population register, is that correct?
Well, lots of countries, yes, that's one aspect of it. They also have quite an autocratic regime, which we don't.
Thank you. And then before we deal with recommendations, can I ask you please some questions about accessibility of testing, please? And can we display your paragraph 76B, which is in your statement, which is 587383 at page 35, please? Thank you. This is where you're telling us about meetings you'd had with the Minister for Equalities, Kemi Badenoch. And then if we look, please, at paragraph 76D, you mention raising deep concerns about the government's communication with what you've referred to as hard-to-reach communities.
Yeah.
I think we've already qualified they should be referred to in a different way because it makes it look like the problem is them rather than they're seldom heard.
Correct.
But could you outline the specific deep concerns you had regarding the communication strategy and what further work was undertaken to address these concerns and improve engagement with the relevant stakeholders, please?
Yes, well, I had done a lot of roundtables and engagement with communities because this was always a priority. We understood that the people who were going to be hardest hit by the pandemic were going to be the vulnerable and the dispossessed and the poor. The feedback that I got consistently was that these communities didn't trust the NHS, didn't trust government, and weren't really hearing the message. My own experience in the music industry, which I know seems very distant from this, is that I used to sell music to these communities. And I know that in order to talk to them, you have to go about it in a very different way. And when I was in the room with our communications team, I couldn't see the people or the strategies or the tactics that were going to be successful in getting these messages across. And I raised these with Kemi, who agreed with the point. And actually, I paid tribute to the communications team at both Cabinet Office and DHSC because they moved very quickly. They were very creative. They brought new people on board, new styles. And at the end of the day, they proved to be very effective. And testing rates in these communities did go up. And ultimately, vaccine rates in these communities were a great success.
Thank you. Still on the same page, and in fact, if we look up to paragraph B, please, of your 76B, you mentioned that the data indicated it was less to do with ethnicity, so much as cultural and socio-economic factors, and the need to understand how groups were behaving to understand how to target NHS test and trace communication.
Yes, there was a story of...
Sorry.
Yeah.
So the specific question, please, Lord Bethel, is could you provide any insights on the understanding gained about cultural attitudes towards testing within these communities and how this was incorporated into the design of the testing strategy?
Sure. Well, if I may give by anecdote, I remember some testing team turned up amongst a caravan park of Herefordshire apple pickers. And when they arrived, everyone climbed out the windows of their caravans and ran off into the trees because they were terrified that it was some kind of police raid because they were from Eastern Europe and weren't used to public health officials being trustworthy. I remember in streets in Tooting, which I know well from having fought an election there, where many women aren't registered in the NHS, and you would have to have people from the same group and often speaking the same village language knocking on the door in order to build the kind of trust necessary in order to reach very, very important vulnerable to the disease. Those are two examples of, I'd say, 100 different local patterns that aren't really to do with ethnicity. They're to do with pockets of culture and also broadly poverty. And it is I'm not saying that everyone who's poor is disconnected with government or everyone that's disconnected with government is poor, but there is a big correlation between that.
Thank you. Can I then ask you a question about location of test sites, please? The location of testing sites in the first 5 months of availability of tests to the public saw many people travelling large distances to have tests undertaken at the regional testing locations. Can I ask, were the locations of the testing sites informed by impact assessments and the needs of the general community, including age, disability, socio-economic factors?
Yes. So to begin with, we were just trying to stand them up wherever we could. And so they correlated to where B and Q was, more or less. But we were conscious from the beginning that by definition, having a drive-in testing site was essentially middle class because you needed a car to attend. And so we prioritised from the beginning other ways of trying to get tests into communities that maybe wouldn't have a car. And that's why things like door knocking and driving to caravan sites became more of a priority. There was a sequence to that. Without doubt, early on, we went for the most convenient template possible, which was the drive-through. But I think that we went a very long way, and I would very much commend Baroness Harding for the huge amount of work that she and her team did on that.
Thank you. Can I ask, would you agree then that the location of test sites was in some instances a barrier to testing?
Early on, the lack of tests was the barrier to testing.
And can I ask you, there's information that suggests there was a shortage of tests in the September of 2020. Do you have any views on whether that was foreseeable and the result of poor planning and response?
I had evangelised for being better prepared for the second wave. I think that plenty of colleagues in Treasury, Cabinet Office had reservations about whether that was necessary. It was in part to protect the taxpayer, in part to protect society from unnecessary lockdowns. It was an argument that I thought was unfortunate, but it was well intended. I think that understanding how pandemics play out and that they take a long time is something that we've all grown more accustomed to.
Thank you. And then Lord Bethell, finally, you've already touched throughout your evidence. You've told us about the scramble and the rethink to approach. You detail within the statement your reflections and lessons learning. But is there any other recommendation? I'm not going to go through each. Your statement will be published. But is there any other particular lessons learning or view you wish to provide to her ladyship to inform her thoughts in respect to Module 7 that you've not spoken about that you'd like to end your questioning with me to just make clear?
I think that, thank you. I think that the science around testing and behaviour change is really moving forwards quickly. And a lot of what we did would have been helped by even the AI that we have today in terms of the data, the surveillance, the interactions with people. There is a tendency for British health to focus on people essentially turning up at a late stage of disease, peeing blood, coughing, and then being treated at the end. The nature of medicine is changing to trying to catch that early, which means that early diagnosis is becoming a more regular part of everyone's life. Bowel tests, prostate tests, people checking out on their hormones. I'd like to see that built much more into the healthcare system that we've got today, because that's the platform on which we can build the future pandemic. In other words, the patient behaviours, the data systems, the at-home testing kits, the domestic industry, all the things that I've talked about. There's a heaven-sent opportunity to use the change in the science, the actual diagnostics, the use of the data, the AI, the interest that people now have to try and prevent disease, to try and capture that excitement and that ability and turn that into a public health good.
Well, Bethel, those are my questions. My lady, they're all core participant
Thank
questions.
you, Ms. Cartwright. Mr. Thomas.
Good afternoon, Lord Bethell.
Good afternoon.
My name's Leslie Thomas and I'm representing FEMHO, that's the Federation of Ethnic Minority Healthcare Organisations. Lord Bethell, do you agree that the track, trace and isolate programmes needed to be localised and culturally tailored to better reach ethnic minority communities and populations? Do you agree with that?
Well, I would definitely agree that best practice is exactly along the lines you described. We were creating a system, as it were, flying in the air, fixing the engines. Under the circumstances, we did have to take a one-size-fit-all approach at the beginning, but we understood the limitations of that approach and did as much as we could, as quickly as we could, in order, as you say, to provide that kind of local and culturally tailored service.
Many of FEMHO members have given evidence about the efforts made by ethnic minority healthcare workers and organisations who, in the absence of centralised initiatives, worked to engage and support their communities during the pandemic. Can you outline any efforts made by the government to engage with those groups or individuals and better utilise their insights and resources to address the gaps in the TTI system and or difficulties in reaching certain groups?
Yes, well, I think the point you make is a very good one. I can give two examples. We did a large amount of roundtables with the Muslim community around Eid when we were extremely concerned about families coming together, communities coming together, despite the rising prevalence. And I must have done 20 such roundtables with mullahs and other leaders in the Muslim community. So we were very much aware of the importance of trying to communicate to key groups. Also, I can't remember the other example. But your broad point, I think, is correct. In terms of the advertising and the use of local media, particularly radio, and which I hadn't previously appreciated, local language television, which is a massive thing in very specific languages. I think we did about 50 or 60 different languages, and there we used doctors from the NHS who had local language ability to appear on televisions where families would have the television on in their kitchen in order to provide a trusted voice to explain some of the principles. So yes, the understanding of that importance was there, and the use of healthcare workers was used at times, but it could have been used a lot more and should be a recommendation of this inquiry.
Let me move on to my final area, and that is lessons learned or lessons to be learned. Were any lessons learned or best practices identified from engaging with ethnic minority communities during the test and trace programmes? And how have these been integrated into current or future public health communication strategies?
So, yes, we learned a hell of a lot. I personally learned a lot. I understood a lot more about your very first point, which is that the frontline workers who took a lot of risks were exposed to a lot of patients, and including the bus drivers and the taxi drivers, were often from ethnic minorities. And although you can say, well, that's more of a socio-economic factor, you still got to wake up that these are people who have got lots of pressures in their lives because of their background and their racial background, and we should have a better consideration for the circumstances they're in. So for sure, I did learn a lot. Whether that is still built in, I'm afraid I can't say. I haven't been a minister since September, but September 2021, but I very much hope so.
Thank you, milady.
Thank you, Mr. Thomas. Ms. Munro, she's just there.
Good afternoon, my lady. Good afternoon, Lord Bethel.
Good afternoon.
My name is Alison Munro, and I ask questions on behalf of COVID bereaved families for Justice UK. The areas that I was going to ask you about was equality and access, and equality considerations, which you have indeed touched upon both in answer to questions from Ms. Cartwright, King's Counsel, and just now from Mr. Thomas, King's Counsel. So what's left of my questions, I hope I can deal with compendiously. And I should also say that I ask these questions very much mindful of and in agreement with your sort of basic premise that health is inherently unequal and that the highest density of disease often strikes the poorest members of the community. So first question arising out of your paragraph 75, was the equality, diversity and inclusion update that you refer to, dated the 8th of July 2020...
would it be possible to have a look at that?
Of course. Oh, you don't have your... Shall I just read it?
Sure.
Read it
yes,
to
thank you.
My lady, as I said, it's paragraph 75 of Lord Bethel's witness statement, and you say this: on the 8th of July 2020, I held a meeting with officials from DHCS on the subject of equality and inclusion communications with NHS TNT, and you give the exhibit numbers and the I&Q numbers. I asked the team to design a risk register to understand how to engage with groups who had poor engagement with NHS TNT and to help guide our targeting of communications. And you go on to say that you received submissions on the 14th of July setting out communications and engagement strategies. So my question was, Lord Bethel, was that risk register and the diversity inclusion update, was that an acknowledgement from the government that the T&T policy was not accessible to all sections of society? And would you agree that consequently people from certain characteristics, you've described them as the vulnerable, dispossessed and poor, were at an increased risk of contracting COVID and sadly ultimately dying?
I think that we inherited an approach to media buying and creativity and all of the skills of modern communication from a health and NHS playbook that was itself very out of date, conventional, and didn't have much ambition for reaching the kinds of groups that we're talking about. In other words, it was a cut and paste from the regular style, which was frankly targeted more at the Waitrose classes than at broader Britain. And so when I did my meetings with officials and agencies, they themselves weren't representative of the groups that we were trying to target, which was something that was acknowledged. It wasn't a, I don't want you to think that I was in many ways repeating what everyone in the room was concerned about. And therefore, because of the pandemic, that gave us a reason and a budget to do things differently and to have more ambition to do the things that, frankly, the health system should be doing anyway, to reach the audiences that aren't typically connecting with government broadly and the NHS and specifically, and therefore test and trace. So this was the risk register is a ministerial device to try to lift ambition and to signal that resources would be available for going above and beyond the norm.
Thank you. My third question, to an extent, I think you've answered that in answer to Mr. Thomas King's counsel, but I'll ask it just to see if there's any further expansion you wish to make. Very much with these vulnerable groups still in mind and the fact that they form part of a cohort of the population, that there are these issues of access about. What, in your opinion, accounted for the failure previously to include adequate support in the broader sense of the word for these individuals in the government's test and trace policy?
Well, as I alluded to before, I don't think it's unique to test and trace. In fact, if anything, test and trace, because it was born of public health and epidemiological disciplines, was more aware than almost anyone else in government of the importance of reaching the groups we're talking about. It inherited a playbook that wasn't sufficient. And government broadly doesn't reach these groups very well. For instance, the pattern of NHS resources like GPs and community health hubs is very much balanced towards richer areas over poorer areas. This isn't a test and trace invention. This is a long legacy and historic inheritance. So I think it's a misrepresentation to imply that test and trace was somehow off the pace on this. Actually, test and trace did things that have never been seen by government before, and I would applaud both the ambition and effort that test and trace colleagues put into trying to reach the groups. Now, I think where you absolutely have a point that is that, of course, these groups shouldn't have been neglected in the first place. And my big pitch to the inquiry is to address that fundamental point. For goodness sake, if we're going to have another pandemic, please not let's have 20 or 30% of the country having very tentative and unequal relationships with the NHS and government in the round. That's the best protection that we could have.
Thank you, Lord Bethel. And finally, again, I think I can roll up my last 2 points. Was the NHS test and trace equality considerations, which is, again, another document dated 8th of January 2021, a guidance, I think it was described as, was that the first guidance on equality for test and trace? And secondly, in terms of equality assessments, which you've referred to, did those come in and were they undertaken after July 2020 or after this second document I've just mentioned in January 2021?
So in terms of the process, I'm afraid I can't answer your question off the top of my head. But I would like to reassure you that the principles of equality and the understanding and the insight that vulnerable groups were going to be hardest hit was absolutely baked in to Taste and Trace from the very beginning. Matt Hancock referred to the Goldacre interrogation of the data, which came back to us as a big shock. I remember the day when I had first sight of that report, and I hadn't expected or anticipated the huge discrepancies that we saw in terms of COVID prevalence amongst ethnic minority groups. And that was definitely a wake-up call that whatever our good intentions, we hadn't achieved fairness and equality, and it led to a doubling down of efforts for sure. And we needed that kind of reminder and that kind of evidence to keep us on mission. So I think, to try to answer your question, we were looking all the time for evidence that we were doing the right thing. And when that evidence showed that we hadn't achieved our ambition, we doubled down and put more resources into the effort.
Thank you very much, Lord Bethell. Thank you, my lady.
Thank you, Ms Munro. That completes the questions we have for you, Lord Bethell. I think it probably completes the burden we've placed on you in helping us. And if there's something that you haven't mentioned but's in the written material, please don't forget that when I reach my findings and make my recommendations, I take into account all the written statements as well. If I may say so, you've been an extremely helpful, insightful witness, and I'm very grateful for your input. Whether your wife will forgive you for
Yes.
the reference to your father-in-law, I don't know. Putting that into the public domain is something you may have to make up for.
I'm still begging forgiveness from my wife for a lot of things. Thank you very much.
Well, thank you very much for your help. I gather you need to see the next witness, Ms Cartwright, so I'll ask you to come back at 3:15.
Thank you, my lady. My lady, please could Lord Vallance be sworn?
I do solemnly, sincerely and truly
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you for your continuing help, Lord Vallance. I hope the last slot of the week was suitable for your diary.
Thank you.
Could you please give the inquiry your full name?
Yes, Patrick John Thompson Vallance.
Lord Vallance, on behalf of Module 7, can we thank you once again for providing further witness evidence to assist the work of the inquiry. Can we then please turn to your 5th witness statement, please? And if we could move to internal page 31, please. We can see that it's dated the 13th of March 2025. And can I ask you to confirm that the contents of that statement are true to the best of your knowledge and belief?
Yes, I can confirm that.
Lord Vallance, can we please just identify the role you were performing at the relevant time? It's right, isn't it, that you were the chief scientific advisor during the pandemic?
Yes, I was.
And I know you have a huge CV and expertise and background, but it's been spoken about before, so I hope you don't see any disrespect by dealing with your background.
I'm delighted not to go through it again.
And can I say for my purposes, I'm delighted that as part of your Module 7 statement, you provided all of the other witness statements of relevance to TTI to assist our work. And in fact, the earlier Module 2 statement is particularly relevant now to a topic I'd like to deal with you first, please, which is the question of asymptomatic transmission and testing. And I think the best way to deal with that issue, please, is to move to your statement, please, I&Q 238826. That's 238826. This is your Module 2 statement, and move into the internal page of 170, please. That's I&Q 238826. Page 170. Thank you. Lord Vallance, we heard a good degree of evidence this morning from Mr. Hancock, who wished to give his perspective as to asymptomatic transmission and testing, and particularly by reference to his concern that there was confusion and where the confusion came, and particularly by reference to yourself. And so can we work through your statement from Module 2, just so we're absolutely clear of your position as to the advice or challenge you gave at any point to Mr. Hancock in respect of concerns you may or may have not have had relating to his understanding of asymptomatic transmission and testing? Can we then please start with your paragraph 511? You say this: as early as the first formal SAGE meeting, SAGE 2 of the 28th of January 2020, it was recognised that there was some evidence of asymptomatic transmission. The meeting anticipated a specific test for COVID-19 being available by the end of that week, but in low numbers, and advised that currently it would not be useful to test asymptomatic individuals, as a negative test could not be interpreted with certainty. This did not mean that the test would not work on asymptomatic people. It meant that a negative test result could not be safely interpreted as evidence that an individual was not infected. It was a question about test sensitivity and not using it to assure non-infectiousness. Now, can I ask you, in terms of that position, can you just confirm whether that SAGE advice and position, and particularly what that means for testing, from your perspective, was understood to have been passed on to Mr. Hancock?
Oh, yes, I'm sure he would have seen this. We had, I think he was chairing COBRA meetings at the time, and indeed, I think, chaired a COBRA meeting where asymptomatic transmission was discussed. So I think there's no doubt that then and over the subsequent weeks, we were clear that the likelihood of asymptomatic or palsy symptomatic, so few symptoms, transmission was highly likely.
Thank you. Can we then please have highlighted your next paragraph, 512, and rather than me read what's detailed about sensitivity and specificity, I do apologise, it's been a long day. Could you please just, again, in the straightforward explanation, explain what the issue is and what you were advising in relation to being able to test on a PCR someone that was asymptomatic or symptomatic.
Well, the first thing we wanted to know was that the test picked up COVID and didn't pick up other things. So you weren't getting so-called false positives, people who had other diseases who were appearing to have COVID. And the second thing, which is the ability to pick up everybody who's got it. In other words, there's a threshold of virus below which it might not work. So that's the sensitivity. Were there a number of people who might have had the infection, but they had very low viral amounts, which meant you didn't pick it up. And those were the things that needed to be sorted out in order to be sure when the test was giving you a reliable negative result, i.e. you didn't have the disease for sure.
Thank you. Now, if we can then move to the next paragraph, please. You tell us that as the pandemic progressed and data increased, the evidence of asymptomatic transmission became clearer, though the precise ratio of symptomatic to asymptomatic cases and infections remained uncertain. There was also a debate among scientists as to whether there was true asymptomatic transmission or transmission by symptomatic people, i.e. those with few or mild symptoms. And you say this early CRIPS for Cobra, which at that time was chaired by Mr. Hancock, noted the likelihood of asymptomatic transmission. And again, are you clear about that?
Yes.
Now, you then also referenced, I think, the emerging literature that was supporting asymptomatic transmission and giving one example there from the 30th of January of a journal published in the New England Journal of Medicine.
Yes.
Thank you. And again, the inquiry's heard some evidence from both Professor Fraser and Sir Paul Nurse as to what their research is at the relevant time from February through to March, was identifying as to the significance of asymptomatic transmission and testing. Can we then please move to the 11th of February? You referenced then SAGE 6 recorded that peak infectivity is probably around the start of symptoms onset and that virus shredding may reach significant levels just before onset of symptoms and continues for 1 to 2 days after. And you then say that the revised reasonably worst case scenario, is that what RWCS discussed at SAGE 11 on the 27th of February, stated that 80% of the UK population may become infected with an overall 1% fatality rate in those infected. Only a proportion of those infected will experience symptoms. Is that correct?
Yes.
And again, we've heard some evidence about PCRs, but can you just explain, when you talk about virus shredding and the levels at 1 to 2 days, can we just, again, have that in complete layman's terms that would assist a layperson at a SAGE meeting to explain complex medical concepts to someone that does not have a scientific or medical background?
Yes, so viral infection starts, you catch the virus, and at that point you may have very few viral particles, so you wouldn't pick that up. But quite quickly the virus replicates, and as it replicates, you start shedding some of the virus, and that's when you become infectious to other people. And what this tells us is that the shedding of virus, the virus actually coming out of your nose or mouth, is high before you get symptoms. And that is when you peak infectiousness around that time before you get symptoms and during the first few days of having symptoms, which again indicates very clearly that there's going to be high viral shedding and therefore the test would pick up a positive case before you have symptoms.
And so again, the test here, would you agree, would be the PCR, the polymerase chain reaction PCR test that was at that stage the gold standard for detecting COVID virus? And is it right that it picks it up when that virus shredding starts happening, but also, as the gold standard, it also picks it up long after the sort of infection has passed because it still is that sensitive?
Yes, so that was the only test that was available at that time. It's very, very sensitive. And as you say, it will continue to pick up the shedding of virus even when you may no longer be infectious.
Thank you. And in terms of the way you're helpfully describing it and explaining it within the inquiry, would you be explaining it in the same way to the relevant ministers, civil servants and officials that were in the meeting where they had come to SAGE and the experts and yourself for advice to inform their policy and decision making?
Yes, but also in any department, and particularly the Department of Health, of course, there were many medical experts and many scientists who would be there to advise people on what this meant, and of course Public Health England experts as well. So there would be many places in which this can be explained.
Thank you. Now, continuing, please, with paragraph 514 on page 170, please. You tell us that on the 13th of March, in your interview with the Today programme on Radio 4, you said that it looks quite likely that there's some degree of asymptomatic transmission. There's definitely quite a lot of transmission very early on in the disease when there are very mild symptoms.
Yes.
And so, again, this is you making a public statement to assist the general public. And is there any doubt that you would have been saying the same things in the SAGE meetings and the advice provided to officials?
Well, there was no doubt what we were saying in the SAGE meetings. The previous minutes from February the 6th make that clear, and this is what would have been said in all of the meetings that we had.
Thank you. Now, we can then go to the next paragraph, please, paragraph 515. You tell us then about SAGE 16 from the 16th of March. It was noted that antibody testing is particularly vital to address the central unknown question of the ratio of asymptomatic to symptomatic cases. And you tell us that this was in the context of a discussion on the importance of scaling up diagnostic testing to manage the epidemic. You say, I made a similar point the following day in evidence to the Parliamentary Select Committee on Health and Social Care.
So the point here is that if you've been infected, the presumption is you would develop an antibody response, and therefore by looking at the antibody responses in the population, you could work out how many people might have been asymptomatic throughout the entire duration of their infection. In fact, that turned out to be very difficult to get those data, but that was the idea.
Thank you. Can we then deal with the 11th of March, which is dealt with at paragraph 516, where you say this: I am aware that there appears to have been some confusion about the efficacy of testing people without symptoms. And you describe that on the 11th of March 2020, a WhatsApp exchange took place about a public statement concerning the Prime Minister's contact with Nadine Dorries MP, who had tested positive for COVID-19. The proposed draft circulated at 10:15 contained a line saying that the Prime Minister did not have symptoms and would not be taking a COVID-19 test as, quote, there would be no point in testing as it does not work on people with no symptoms. And you say this: I intervened to say that this was wrong, not correct that the test does not work on people with no symptoms. It does, and that's why we contact trace. In this case, it is the contact tracing that is key to who gets tested. And so can I ask you then, just to give a bit more context, because Mr Hancock in particular has sought to detail the exchange that happened on the 11th of March to explain his understanding as to what he was being told from the scientific advice he was being provided from others and from yourself on the 11th of March of 2020.
Well, I think this is very clear that you test people who are contacts of those who had COVID to try and find out if they are infected. And that was going on in other places around the world. And there was a reason to do it in this country as well. But, of course, a negative test wouldn't absolutely guarantee that you hadn't been infected. So that's why an isolation period was in place for contacts, irrespective of whether they had a negative test. So the positive tells you have got COVID. The negative doesn't absolutely assure you haven't.
Thank you. And can we please just go to the text messages that were, the WhatsApp messages which were gone through with Mr Hancock this morning. Please could I ask to be displayed INQ 102697 and it's internal page 15, please. That's INQ 102697, page 15. So, sorry, 16. Sorry, my format's slightly different. Thank you. Now, we can see thank you, at the top of that page, we can see the exchange that's happened. If you can see that perhaps if you read for yourself more than I going through, it says, having spoken to Chris Whitty, and this is and Public Health England people, I'm with now, Patrick, what you've said is not right. The clinical advice I've had is that the test is not reliable on people without symptoms. The reason is that there are so many false negatives when there are no symptoms that testing is counterproductive. Can the scientists please clear this up urgently? And then if we follow it down, we can see then Chris Whitty saying not reliable is correct. It can pick up some asymptomatic cases, but not advised. And then we can see again Chris Whitty saying, Patrick and I will do a joint note, not on WhatsApp, on testing. And if we go over the page, please, to page 17, you say at 10:47:22, agree, not reliable, not does not work. And so can we be clear about what you say this exchange represents, particularly in the context of the other occasions when you had discussed the issue of palsy or no symptoms and testing?
Yeah. Well, I was worried that the view that this didn't work would obviously mean you wouldn't use it at all for contact tracing. That was not correct. It'd work, but it may miss people and may give people a negative result who actually were infected. And that's then a policy choice as to whether you want to use that for contact tracing or not. And I think that's, to some extent, the exchange that Mr. Hancock was presumably having with Public Health England officials and others.
Was there any difference between your opinion and that of Professor Sir Chris Whitty's?
I don't think so.
Thank you. And if we then go back into your statement, please, we've used the underpinning document that Mr. Hancock wished us to go through, but can we go back to your witness statement 238826 at page 171, please? Again, what's using... Thank you. Thank you. We can see essentially you set out in your Module 2 statement the exchanges over WhatsApp that we've just looked at together. Can we then go over the page to 172 and to paragraph 520, please? You say this, following this exchange, I sent a message to the Chief Medical Officer asking if he could draft something on testing. And in quotes again, you've got, it's not true to say it doesn't work. It can detect cases but would miss a lot and so isn't recommended. And you say again, this refers to using a negative test result to assert that someone is definitely not infected. The Chief Medical Officer expressed his agreement and commented that this was a classic example of why government by WhatsApp is not the way to deal with these kind of things. Is there any expansion you wish to say about that paragraph, please, Lord Vallance? Well,
I think it was clear that Chris Whitty would then make sure that within the Department of Health this position was clearly understood, and that the fact that the tests did pick up people who were asymptomatic, but not necessarily everybody who was positive who was asymptomatic, and could take that into account with their planning on what their policy should be.
Now, can I ask you from your perspective, where you have the Health Minister having, I think, some confusion or needing clarity, when we looked at the 11th of March, can you help us in terms of on the range of whether that's concern or understandable, depending on where the advice is coming from, your views, bearing in mind particularly that this is the relevant minister that's making policy and strategy decisions?
Well, I was obviously worried that he was getting advice that it, or thought he was getting advice that it didn't work, because that's incorrect. I was perfectly happy with the idea that he was getting advice that says it may not be reliable. That is correct. It may not pick up everybody. And they were important distinctions. So once that was clear, I was happy that he'd understood the position and the people in the department were then reinforcing that.
Thank you. But then if we pick up the chronology, please, at paragraph 521, you say this: the issue arose again in April 2020 when I became aware that Mr. Hancock had been saying that PCR testing did not work on asymptomatic individuals and that policy was being based on this. And just pausing there, where had you been getting the information that Mr. Hancock was repeating the similar position that had been expressed earlier in March?
I can't remember exactly, but I think I was in a meeting where I heard this said again, and I think I again raised that's not correct. And I got the impression that then this was being promulgated as an idea in the Department of Health. And so I wanted to speak to Chris Whitty just to be absolutely clear that we were on the same page as to what the situation was. And we obviously were. But as a result of this, I decided that I needed to get something, again, written down so that there could be no ambiguity about what the position was. And I asked somebody within the Government Office for Science to do a piece of work to quickly document what the situation was. She did that very day, and the next day I sent the paper across to say, this is the position. Can we please just make sure everybody is clear as to what this means?
Thank you. And perhaps if I give some wider context to this time frame that we're looking at, would you agree it was a significant time frame because decisions were made on the 12th of March of 2020 by the government to move from contain to delay? And so if there was a misunderstanding about the virus and the testing, that could have been affecting policy decisions that were being made. I appreciate there's capacity, but would you agree that that is a significant factor?
Well, I think it's a significant factor that I thought we'd put the issue to bed in March. I thought it was actually clear before that, but I thought we'd put it to bed in March, and obviously wasn't sorted out in some people's minds by mid-April. I think the decision around stopping community testing was a very, very different decision. It was based, as I understand it, within the department on a very simple problem, which is there weren't enough tests to test people coming into hospital.
Thank you.
And that therefore there were people coming into hospital with doctors unable to ascertain whether they had the disease. So that was a pragmatic decision to use the tests, quite rightly in my view, for people who are ill with COVID.
Thank you. Now, you've just detailed what is set out in paragraph 521. You exchanged those messages with the Chief Medical Officer on the 13th of April. And again, you confirmed that while the test was likely to be less sensitive in asymptomatic people, it was not correct to say that it did not work. And you say, I added that while it was not known whether it was helpful or not to test asymptomatic people, South Korea was doing so. And you detailed that the Chief Medical Officer expressed agreement and said that he had changed a document to reflect this. And can you give us any more detail? What was the document that he had changed to reflect this? Does that suggest?
I think it was probably their testing strategy document. I can't remember exactly which document it was.
And again, we've looked, and the inquiry, I'm not going to take you to testing strategies. We know that there's a lot of documentation as to testing strategies as it evolved to the strategy of NHS Test and Trace were evolving over April. You then go on to tell us, and so I think the paper that was produced, if we could just briefly display that, it's INQ 871777. That's INQ 871777. Apologies for the delay. Thank you. And so is this the paper, if we scroll down, where it was the clarity as to what you said around that you could be, that there was a value to PCR testing, even individuals who are asymptomatic, because it would pick up those that had the virus?
Yes.
Thank you. Thank you. Now then, if we go back to your statement, please, at paragraph 522, at page 172. You say this: the following day, the 14th of April, I sent an email to others in the Government Office for Science asking for some work to be done on this topic. I was unsure where Mr. Hancock was getting his advice from, and I wanted a definitive position documented. This led to an academic secondee to the SAGE Secretariat producing a rapid review paper that we've just looked at together, which laid out the evidence. It concluded that PCR screening of asymptomatic individuals is not only possible but useful and being employed elsewhere. I subsequently provided the paper to the Chief Medical Officer, saying that I thought it was important that Mr. Hancock see it, as, quote, he is firmly under the impression that tests don't work in asymptomatic people, and this is clearly wrong. You go on to say, in a later email, I added that I thought there was a pretty high rate of asymptomatic infection in older people, and that this meant that testing was important and that isolation on return from hospital should probably be for all, not just the symptomatic. and you say that the CMO took the matter forward, and I understood that the relevant policy, the social care plan, was changed as a result so that everybody leaving hospital for a care home would be tested.
Yes.
And so in terms of your expression or view or what your account is, because again, Mr. Hancock was at pains to say about his views about confusion in his advice. Can we be absolutely clear about what your position is about Mr. Hancock's knowledge and understanding around the value of testing of asymptomatic or quasi-symptomatic individuals on the 14th of April before this note was shared?
Well, I think all of this is backed up with documentary evidence. This is the advice that was given. What I can't comment on is what advice he might have been getting from within the department, and therefore I don't know what else he may have heard. And he certainly had a lot of people from Public Health England and elsewhere who would be advising him on a day-to-day basis and feeding in scientific advice. But this was the very clear position and was the one that Sage had discussed as well.
Thank you. Can I ask you, the document we looked at very briefly that had been drafted by the member of the Secretariat of Sage, did Mr. Whitty have any input in that document, or was that a separate document that was then provided to Mr. Whitty?
It was provided to him.
Thank you.
I mean, I had just got frustrated by the fact that this kept getting repeated and just wanted something that was absolutely clear that everyone can have one version of, and that's why this paper was produced.
Thank you. I'll just complete the topic with your 523 before briefly taking you to an email exchange that Mr. Hancock dealt with this morning. You say this at 523. I'm asked about the extent to which concerns about the reliability of testing of asymptomatic people affected the response to COVID-19. What was evident from an early stage and was made apparent in the science advice to ministers was that asymptomatic infection and transmission were possible and even likely, but we did not know the proportion of asymptomatic infection as described above. I sought to correct a misapprehension on Mr. Hancock's part that the PCR test did not work on asymptomatic patients. I do not know where this incorrect advice came from or why it was so firmly adhered to.
That's correct.
Now, can we display next, please, briefly? There's a whole number of emails and documents that I went through with Mr. Hancock this morning, but can we display INQ 93326? That's INQ 93326. And if we can move to page 3, please, of this document. Thank you. Now, the owner of the cell phone, this is Mr. Hancock's messages, and we can see at 8:16 he details Chris Whitty has done an evidence review and now recommend testing of all going into care homes and segregation whilst awaiting result. This is obviously a good positive step and we must put into the doc. And then the clarification, just checking this includes all those asymptomatic too, right? And obviously you're not on copy to these, but it seems to be, it evidences the debate you've already told us about and what led you to provide the note from the SAGE Secretariat to inform and give the absolute clarity as to your position. Is that correct?
Well, it looks like it. I don't know what these are. This is a policy discussion and they're taking into account the advice that's been given.
Thank you. I'm not going to take you through all of the exchanges that Mr. Hancock produced and we went through this morning as to emails to evidence how that informed the change in policy. But can I ask you, because there was a suggestion that on the 11th of March, so the exchange we looked at, the WhatsApp, off the back of Nadine Dorris exchange, if we call it that Mr. Hancock was saying that he had expected a paper from yourself and Mr. Whitty, and that the next he heard anything in reality was the 14th of April. So some suggestion that had there been any ambiguity about confusion or what he needed to know, he would have expected a paper sooner than the 14th of April. Lord Vallance, is there anything you wish to say to respond to the evidence we heard this morning on that topic?
Well, I think we've just seen it, that I had an exchange with Chris Whitty saying, is it now clear that asymptomatic people can test positive? It's just that not all of them will test positive. To which he said, yes, we just looked at it. And I said, will you now deal with that in the department, or words to that effect? So I think that was dealt with.
Thank you. Just excuse me, there's one document I need to go through with you, and I've just mislaid it, so I do apologise, Lord Vallance, for keeping you waiting. Thank you very much indeed. Lord Vallance, the next topic I want to deal with, please, is it's using some entries from your evening notes. And can I apologise that we're revisiting your evening notes, and perhaps if I give some context to these, Mr O'Connor, King's Counsel, went through some of these evening notes in an earlier module, and perhaps if we clarify the context to them. I think, first of all, you had never intended anyone to see these evening notes. They were personal reflections at the end of the day. Is that correct?
Yes, I'm not even sure that they were really reflections. They were sort of spontaneous ways to sort of decompress at the end of the day.
I think Mr O'Connor described them as late-night musings.
Yes, that's probably
And
accurate.
so I apologise that we're going to go through some very brief entries that are selective from wider entries of those late-night musings. But can we please just work through the few brief entries that we have, and then there's a number of them that I just want to ask some questions, because they do identify a little of the timeline. Now, this is the first one to be displayed on the screen, but just to give some context, the day before, on the 1st of April, there was an entry, testing, still not in a good place, PM Wright getting tetchy about it. And then if we move, now the following day, we've got Crick offered 300 scientists and got no response from Public Health England. Crazy. And letter came from Peter Ratcliffe. We've helpfully had clarified, well, I have, that Sir Peter Ratcliffe is a Nobel laureate and perhaps one of the eminent experts in this area. Can you give a little bit more context that might assist some insight to this late-night musing, please, Lord Vallance?
Yes, on the 10th of March, I got a message from Sir Paul Nurse, which outlined some of the science they were doing in the Crick that might be useful to COVID. I think I had a conversation with him at the time. It was quite detailed about the types of science they were doing. And we also talked, I think, about testing. 7 days later, Peter Ratcliffe sent a message saying that they could help out and what was needed, which I sent on to Public Health England, and also spoke to Chris Whitty about it, and he answered a letter at that time as well. So that was a very valuable thing. On the 2nd of April, or the 1st of April, I sent a message to Peter Ratcliffe saying I heard that the Crick was now up and running with testing, and he said yes, and then gave me a lot of details of what they were doing. And one of them was that they'd offered 300 scientists, but had run into difficulties with Public Health England, who wanted their occupational health people and their contracting officer to do things, and he had no contact from the contracting officer. And I think I wrote in a response to him that on the face of it, that sounds balmy, and I'll look into it. And I did actually then speak to somebody from Public Health England that afternoon, and later on that same day, Peter Ratcliffe came back and said, thank you, the position at Public Health England may be moving, and I did finally get through to the head of contracting. And I think something did happen as a result of that.
Thank you. I think that partially answers some of the follow-up questions I had, but just to complete the topic on this entry, please. Did you or the Government Office for Science have any involvement in promoting liaison with academics or practitioners in this sector?
Well, generally, yes. If you look at two other things that I was doing at the time, and again, my role was not operational, and I tried to stop that. I did get drawn into operational things with the Vaccines Task Force and with the genomic testing. And if you look at both of those, my principles for the Vaccines Task Force was to bring together academia, government, and the private sector, led clearly by one person, to try and make sure that worked. And on the genomic side, we founded COG UK as a network of academic labs to do the genomic sequencing across. So the academic community was very, very linked into what we were doing in the Government Office for Science.
Thank you. And I think perhaps bears repeating. I think the position has been very clearly set out by the Government Office for Science that that you and Sage provide advice to the Prime Minister and members of the Cabinet and the departments, but essentially you are not implementing policy or decision-making or strategy. And would you also agree that on many occasions you were only being asked on a specific issue to give advice without being over the nature of the advice, just answering the question that was brought to Sage?
Well, that was the SAGE remit, and as I say, in some cases, like vaccines and genomic sequencing, I also pushed hard for the sorts of things that I thought needed to happen. But yes, it's not an operational department; it's a very small department, and 50 or so people. And of course, there are operational organisations like Public Health England with 5,000 or more people, including many scientists who operationalise these things, and policy departments like DHSC, which make the policy.
Thank you. And then can I ask a follow-up question again by reference to this entry relating to the offer from the CRIC? Could you assist as to what steps you took to ensure that government took such offers seriously?
Well, every time I got an offer from somebody that I thought was credible, I made sure Public Health England knew about it. And then, of course, it's up to them to make sure that they either take it or don't take it as they're trying to design a system.
Thank you. And then can I capture then your view and assessment of the scientists and expertise that existed at the CRIC and the capability and offer that they were making to government as to your views of it as a helpful and useful resource or otherwise? Can we just perhaps contextualise your view?
The Crick Institute is absolutely the top research institute in this area, not in infectious diseases, but in general in biomedical science, one of the top institutes in the UK. It's full of absolutely outstanding scientists. It's got a very well-funded structure. It's got core facilities that allow you to do things at scale where necessary. And it's got 2 Nobel Prize winners in it. It's an outstanding research institution.
Thank you. Can we then move, please, to the next entry from your evening notes, please? 14th of May. Meeting on test, trace and isolate, and for some reason neither Chris nor I have been invited. That's the Chris there, is that correct? That would be Mr. Whitty. Dido Harding is impressive and has finally got a grip on the TTI stuff. Is there any other information or context you'd wish to give that assists in any way with this entry in the evening notes?
Well, I'd become extremely worried during March that the capacity and capability of PHE to do the testing that was required was lacking. And there may be all sorts of reasons for that you need to ask them and their chief executive at the time, Duncan Selby, about. But I was worried about it, and there'd been a push from number 10 to have a much more determined approach to trying to get this scaled up. I don't know how Dido Harding was appointed to this, and I don't know how the actual structure was decided. But obviously, at this moment, I thought, thank goodness somebody's taking this seriously and trying to get on top of what we need to do to get testing scaled up and active.
Thank you. Can we move then, please, to the next entry of the 18th of May? You can see TTI now talking about 500,000 tests a day. Must recall that the reason that ONS is doing the study is that when I asked PHE to do it, they said no, in brackets April. And the issue of testing asymptomatics, brackets, or not testing, that was a pure DHSC refusal until I wrote the email, remember, DHSC tried to stop. Again, if you're able, Lord Vallance, is there any additional context you'd wish to give to this?
Well, there are 2 different things here. There was the issue of community testing, and community testing was about trying to get, on a regular way, an assessment of what was going on across the country. So it wasn't diagnostic testing, it wasn't test, trace and isolate, it was to try and work out where the infection was, how many people had it, how it was changing over time. And it was something that SAGE had asked for very early on. And in fact, if you go back to exercise Alice from 2016, one of the exercises around this, that said that sort of thing needed to happen. And we had said repeatedly, we need this information. And there was a very important meeting in April, I can't remember the date, when the person from PHS said, we can't do it. And at that point, we asked the Office for National Statistics, said, can you do it? And they said yes, and so they took it on. That was an important part of it.
Thank you. Can we then move to the next entry, please, from the 27th of May? And again, Lord Vallance, I've already caveated that these are out of context. There are plenty of other notes, and it's not said that all of these entries represent everything you were making notes about relating to test, trace and isolate. But can I ask you about the 27th of May entry, TTI, lots of lock them in filing cabinets type approach to isolation. I said clearly that SPI-B said incentives more important than punishment to those who don't. PM agrees, but DC, pausing there, is that Dominic Cummings?
I should think so, yes.
And CX, is that for Chancellor?
Yes.
Very against regards fairness is a big issue. And the Dominic Cummings position undermines it. The meeting on TTI was a shambles only saved by Dido. Again, is there any further context, if there is any, to provide?
Well, I think it's clear from other entrants in my witness statement that behavioural science was very, very clear that incentives were more likely to work than punishment, and gave several examples of the types of incentives, which can be practical help with isolation, it can be monetary help, it can be sick leave pay. There are a number of things that the behavioural science indicated would help. But clearly in this meeting, it was one where people were going in another direction.
Thank you. Can we move then next to the 6th of July, please, where it's recorded NHS Test and Trace has now done what we said and set up a central team, in brackets the feds, close brackets, to assist local responding, in brackets, exactly what Germany did. Can I ask for clarity around this? And I don't know whether you can give further context. We've heard some evidence that in Germany they operate a system where essentially universities are on stand down but have an ability to agilely assist, which is part of the German federation system to scale up testing. Is that any relevance to the reference to the Germany did in the feds?
Well, yes, it is partially. I mean, they have a Lander system anyway of government, which is very decentralised. It's very different from the UK. And they had a system which brought together academia, industry. So they have a lot of diagnostic capability in industry in Germany, and they brought that together. But they then had a central team that could supplement that if needed, and that's what this is referring to, the idea that you have local application, whatever that is. It could be government laboratories, it could be industry laboratories, it could be academic laboratories, and then supplement that with I call them the feds here, to send people in when you have a need for more help.
And can I ask you, Lord Vallance, we've heard some evidence last week and touched upon it this week about the value of universities being utilised and their laboratories as a potential source for scaling up in future pandemics. Is there any view, perspective, input you'd like to provide on what was on one view from Professor McNally indicated as a potential area where her ladyship might wish to consider, bearing in mind the financial sums that would be needed to retain or supplement the universities that could provide that scaling up role?
Yes, so one of the principles in the 100-day mission that we said was make the exceptional routine. In other words, use things that are used routinely so you can scale them during an exceptional time. And obviously we do have laboratories right the way around the country that could be used. I don't think we can assume that they would be able to do that in an emergency. That would need to be tested, and I think Paul Nurse said that in his evidence as well. The CRIC clearly was able to do something. It wasn't contact tracing, it was doing testing and that part of it, but you'd need to test the ability of that. I think it would be quite difficult to assume that all of that could be stood up, and it goes back to one of the points I made in Module 1, which is that exercises should really test the practical application of these things and the operationalisation, not just the theory.
Thank you. Can we move then, please, Lord Vallance, to an entry from the 27th of July 2020, please? Thank you. It records, Dido pushed to get financial support for people to get tested in low socioeconomic groups. Rishi reacted strongly against that and said, basically, just stop the social interactions. My paper on how quickly this can take off should be listened to. Hancock came in and said, delay the August the 1st additional measures opening up. But the PM says he wants to stick with the August the 1st measures. Rishi is getting very excited about it all and suggested everyone gets tested at work. It's perfectly obvious to me this could get out of control again. PM Dido, who was very robust, for Rishi, it is all about personal responsibility and get the state out. Again, quite a lot covered there, but can you summarise or break down anything else additionally to help us understand this?
I mean, given these are my ramblings, it's a bit difficult to know exactly what was going on. But I think the point, if I remember correctly, the point that I think the Chancellor was making was that if you reduce social interactions and allowed people to go back to work and tested them at work, you might have a positive effect. I think that's what he was pushing for.
Thank you. Can we then move, please, to the 3rd of August?
Sorry?
Sorry, I was asking we can move on to, thank you. The next note, please. It was pointed out that I pushed very early on to decentralise testing and be more like Germany. I put Crick in touch with PHE several times. I think we've perhaps touched upon it, dealt with this issue. Is there anything else, Lord Vallance?
I don't think there's anything else to add to that.
Moving on then, please. The next entry, 6th of August. Thank you. People changing all the time, e.g. no one knows who actually is in charge of Lighthouse Labs. Like wading through treacle to see process from start to end of testing process. Continues the operational mess, confirmed that PHE has had its science stripped out over past decade. Sorry, confirmed, I do apologise. Anything to add clarification to?
I think the Lighthouse Labs are obviously set up under the TTI framework. There was advice being given into the Department of Health at the time, including scientific advice from others. I think John Bell and others were involved in this. I wasn't involved in this operational side of it. And obviously in that meeting, it was quite difficult to see who was actually leading this on a practical day-to-day basis.
Thank you. Can we move then to the next day?
Which may be my fault, by the way. I mean, it may just be I couldn't see it.
And if it is this, Lord Vallance, that we've heard evidence about the system and who was involved. Thank you. The 7th of August, OMG, discussion with testing lead, Emma Stanton. She has no scientists on her team. Why, oh why, is DHSE at this stage, at this point in the pandemic? Spoke to Chris, and again, is that Chris Whitty?
Yes.
And have a plan to help her, but what a mess.
Well, I was obviously just surprised that Emma Stanton, who I think actually was very good, didn't have the science support from within the department that I thought she required.
Thank you. We move on to the 12th of August, please. And in fact, there's 2 entries for the 12th of August. We see PM very agitated about getting new higher throughput tests going. Freaked out because apparently Chancellor told him this morning there is no money for an SR. Pausing out, what's an SR?
Spending review.
Thank you. They have finally clicked on the issue of clock speed. Backward contact tracing only started yesterday, but Dido is trying really hard. Again, can you give any further?
I think maybe the only point I would put, I mean, because some of this is about money, but the point that I would make is that backward contact tracing is something that is really important to pick up clusters and to stop clusters spreading, and was a repeated advice from SAGE right from February onwards that is an important part of the system. So it was disappointing, to say the least, that backward tracing took quite so long to get started.
Thank you. And then moving to the next entry for the 12th of August, please. Then 2 hours with PM, Dominic Cummings, Chief Medical Officer, Case, Mercer, and a couple of others in next 8.
I don't know what that means.
No, thank you. Imran. And is that Imran Mercer?
No, Imran Shafi.
Thank you. Set us up well with some facts and figures and built from the what we know, what we don't know paper. Then did 4 big areas: behaviours, tracing the virus, outbreak management, and is the NHS ready? We voted red, amber, yellow. First 2 got lots of reds and ambers. Pausing there. What's the red, amber vote that's relevant here? Can you give any extra context to that, please?
Well, it sounds like it was a meeting where trying to look at what we knew in those areas and what was actually being operationalised, and people were being asked to say whether we were, green, all good, or red, not good at all.
Thank you. And then we say instincts of this crew is to go for more enforcement and punitive measures. We suggested more carrot. Pausing there. Who's the we?
That would be a SAGE recommendation.
We suggested more carrot and incentives required to make people take a test, self-isolate, etc. But they always want to go for stick, not carrot. Who is the they that preferred the stick to the carrot?
Well, I think in this case it would have been the decision makers for policy.
Thank you. Can we then move, please, to the next entry, the 25th of August? Records interesting email exchange with Sue Hill. Is that Dame Sue Hill?
Yes.
And others that clearly says that the reason NHS labs weren't used for testing was that they were too expensive. You couldn't make it up. And so, Lord Vallance, is that relaying some information you were provided with that had come from Dame Hill?
Well, I asked why we weren't using more regional labs, and the answer I got in an email from the same date is one of the reasons that the NHS labs had not increased capacity was the cost of the testing needing further funding, etc. The recent approval by DHSC of the business case for the NHS to increase delivery to 100,000 is predicated on improvements in the cost/efficiency, etc.
Thank you. Can we move then, please, to the 7th of September? Chief Constables have said current rules too complex and difficult to police. Chancellor blocking all notion of paying to get people to isolate, despite all the evidence that this will be needed. Lord Vallance, is there any extra context?
I don't think there's any. I mean, that was presumably in a meeting that I was at.
Thank you. And Lord Vallance, we've also heard from the National Police Chiefs Council and Mr Hewitt's views on the rules that the police have to enforce. Thank you. If we can move then to the 10th of September, please. Moonshot with PM. Is this reference to Project Moonshot or Operation Moonshot? Sorry.
Sorry. Well, I think this was rather alarming that the PM wanted to know what the figure of 265,000 was that he was being presented with as a success story. Was it the number of tests actually taken, the number of people tested, or both, or something else? And he didn't get a very clear answer from the TTI team, and I must say I found that slightly surprising.
Thank you. And we can see, started off with what is happening with existing testing and why it's so constrained and people having to travel miles. A complete car crash. PM wanted to know whether the figure of 265,000 was tests, people tested, or both. They just couldn't answer questions. It was alarming. Chief Medical Officer and I agreed that this is a mess, and his concentration on Moonshot has caused the whole story to be about that rather than the cautious message about sticking to the rules. Lord Vallance, is there anything else that you can assist with by reference to this entry?
I don't think I have anything else to say on that.
Thank you. If we can move then to the 14th of September, please. Ray PM, we got him to understand the need to separate the TTI and the Moonshot, have clear accountability for the latter, stop talking about it, and get TTI sorted out with priorities published. Is there any...
well, again, I think that's pretty clear.
Thank you. 2 days later, please, 16th of September. Testing has the loo roll panic phenomenon, where it is overwhelmed because people perceive shortage. Simon Stevens says NHS labs are at 100% capacity. And is the loo roll panic phenomenon a reference to the public and how they stop buying?
Yes, I mean, it was just, I think somebody must have said that in the meeting, that obviously at the beginning of the pandemic, everyone went and bought loo rolls, and suddenly there weren't any loo rolls anywhere, and that's a sort of behaviour phenomenon. And there's a worry that because the message was that testing was in short supply, people may go and get tested and use up all the short supply, and we'd end up with a problem. I think that's what this refers to.
Thank you. Lord Vallance, I've just 4 more entries, and I suspect then I've utilised all of my time with you. If we can move to the next page, please. 25th of September. PM, punish people who won't self-isolate. Punish people who aren't doing the right thing. Close some pubs and bars. We need a lot more punishments and a lot more closing down. I put a message in chat that support and engagement, very important to get adherence up. PM ends with massive fines, massive fines.
Well, I said in an earlier one that the PM was on the side of doing incentives. I mean, I think he would change quite a lot between meetings.
Thank you. And again, against the time frame, we know the decisions that were being made around isolation, payments, and also the enforceability of isolation that came in place in England, first of all, and then later in Wales. We can move to the next entry, please. 25th of September. PM obsessed with testing again, wants to know why not ramped up and why is turnaround so slow? PM asks, why is the orange line in the graph so wonky? Dido explains that things happen that mean their performance is not linear. Is that essentially just someone like myself that would struggle with interpreting the graphs when they were presented?
Possibly. I can't remember the specific example here.
Are people actually doing self-isolation? I argue that low levels of isolation is the key. They, of course, go straight to enforcement. PM says, we must have known this wasn't working. We have been pretending it's been, whereas secretly we know it hasn't been. Hancock lets out a big sigh. Hancock says other countries are asking him, how have you managed to do this? Is there any other context you can give?
Well, this is a very fraught time when the prevalence was going up pretty fast, and it looked like things were getting out of control and would get out of control to the extent that further very serious restrictions would need to be placed. And I think this reflects some of the anxieties at that time.
Thank you. And finally, on the evening notes, 28th of October, please. Sorry, there's two more. I do apologise. I've given false hope. 20th of October, Dido gave a further upbeat assessment of where test and trace is. How correct is this? They now have a support package in place for isolation and are calling people. They say 15 to 50% adherence. PM completely obsessed with testing as a solution, even as numbers so bad that it's obvious more action is needed.
Well, there are two things to say here. It's really important as we talk about testing to remember testing is only done for a purpose, and the purpose in this case is to isolate and try and make sure that isolation occurs. If the isolation isn't happening, then the testing isn't really doing what it's supposed to be doing. And again, this was a time when the prevalence was going up very fast. And I've made the point in previous modules that test, trace and isolate doesn't work when the prevalence gets so high that it's swamped. It stops being effective.
And finally, just the last entry, please. Which now, in fact, it's the 7th of January 2021. I'll just read this. PM meeting testing. Testing performance looks much better. Now the challenge is self-isolation. Dido saying we need to get better schemes in place to help people isolate. PM says we haven't been ruthless enough. We need to force more isolation. I favour a more authoritarian approach, close quote. Rather late in the day, the PM is understanding that incentives, in brackets, or removal of disincentives, close brackets, need to be in place to help people, but his instincts are punishment, not help. Sounds like a good testing system is gradually coming together and will be ready when lockdown released. Is there anything?
I think that was the position.
Perhaps, Lord Vallance, that's our time to gather up and appropriate place to end. Can I thank you for answering my questions? My lady, there are no core participants.
There are no more questions for you, Lord Vallance, and I think it's probably the last time we're going to place the burden on you. I'm truly sorry, because I do understand how difficult it must be. I appreciate you're now in a different role, but thank you so much for all the help that you and your colleagues have given to the inquiry. And maybe as a minister, you may be able to in a position to help implement any recommendations I make.
I hope I will be.
Thank you so much for your help. Very well. I shall finish now, and I shall return for a 10:30 start on Tuesday, the 27th of May.
Thank you, my lady.
I hope people get a decent weekend.
Thank you.